Hi again.
Hi.
You said Morgan? Okay, I see her. She should be. Yep. So Heather, we've got a couple people that are going to join the Zoom to hear your part as well. And then we'll have a couple people here in the room.
Okay.
Hi, Morgan. Thanks for joining. And I think they're about to have a baby, Heather. So we might have one or two trickle in.
Okay. Well, if you hear some background noise, they're having a baby out there and not thrilled about it.
You guys are welcome to come up here if you want. Get a little closer. Okay. So I think this is everybody.
Hey, Dr. Corey. Hi.
Hello.
Okay, well, thank you guys for coming and being here. I have Heather here that's going to talk to you guys a little bit about kind of a little bit of her story. I'll also tell you. You have the floor, ma'am.
Okay. So like she said, my name is Heather. I am from Mercy Springfield, so a little ways away. So a little bit about me. I am a labor and delivery nurse, now a labor and delivery educator. The reason I'm speaking to you guys, I had an AFE when I had my baby. First baby, totally normal pregnancy. I'm labor and delivery nurse, so I knew about AFE, learned about it. It was always one of those things of you learn about it and then you kind of put it on the back shelf because it's one of those things you hope you never see or never have to deal with. Never in a million years do you think that it's going to be part of your story. But for me, I came in, labored for a really long time. My daughter decided she was a little too comfortable in there. I labored for about 17 hours before I had my event. So when I had my AFE, my daughter had a very large decel. She went into the 60s, into a terminal bradycardia. At the same time, I started puking blood. Hindsight is 2020. They now realize that I was in DIC. At the time, I had been throwing up so much that they said that I had just kind of worn sores in my throat. It was why they were seeing the blood. But again, hindsight is 2020, and I was already in DIC. And I was going in and out of being disoriented. So I didn't know where I was. I had impending doom, telling them to save my baby. I was going to die, things like that. And then they put me to sleep for my C-section. During my C-section, I coded twice during my procedure. Was in DIC. Ended up with a hysterectomy with 4,500 of blood loss. By the time it was said and done, I got over 60 units of blood products, and that is including clotting factors, so FFP, cryo, things like that. I ended up with a hysterectomy. During the hysterectomy, while they were doing that procedure, the cardiovascular surgeon was in the room putting me on ECMO at the same time. And ultimately, ECMO was what saved my life. That allowed my heart and lungs to heal, obviously. I was on ECMO for 2 days. And then at that point, they only took me off because I was losing circulation in my leg. And that's the only reason that they took me off when I did. They took me off ECMO, and the cardiovascular surgeon didn't think I was going to make it. I did, obviously. I was in ICU for a total of 9 days. In the hospital for a total of 2 weeks. The NICU discharged my daughter in, I think, 3 days. So she did very, very well. The hardest part out of all of it, like I said, I was a labor nurse, and all of this happened in my home unit. All of my best friends taking care of me, coding me, all of those things. So that was a whole nother layer to my situation. But we are all doing very well. My daughter is going to be turning 6 in January, going to kindergarten this year, doing very well. But yes, so that is my story. It is very different being on the healthcare side of it, especially as a survivor, and being already in this unit and being a survivor on the healthcare side. You get kind of a different perspective. Second victim is definitely a real thing. I see that every day with my friends and my coworkers. So definitely a real thing. Are there any questions that you guys have for me?
So did they do general anesthesia?
Yes, they did. They did from the get-go for me. And then, obviously they didn't know what they were getting into initially. And then once things did really start to go south, they said it was really one of the many miracle things that they did do general anesthesia from the get-go, because they would not have been able to get me intubated, where I normally am probably not a difficult intubation. At that time I was, and it was a really hard thing for them to get me intubated.
So do you think they have the diagnosis before they're cutting, or they just thought this was like fetal decelerations, we're getting the baby out, emergency C-section? And then
initially they thought it was just decelerations.
Yeah.
Because they didn't recognize the DIC initially. They recognize it looking back.
So how was it diagnosed? Because normally you're lucky. I'm glad you're alive and well, because most people, it's a pathological diagnosis, AFE. And
right.
How did they really, just based on the DIC, or were they able to figure that out?
They based it off of the DIC, and then throughout the procedure, I was profoundly hypotensive, more so than what they would expect for a normal general anesthetic procedure, which is part of the disease process of AFE, and then just the amount of blood loss that you would not normally be able to explain with a normal postpartum hemorrhage or something like that. Yeah. It's basically, they ruled out everything else and said this really only fits with this.
So were there any?
Going to work. Darn it. I know we have Morgan online, and then Amy here in the room. Morgan, do you have any questions specifically regarding Heather's story or Amy?
I think she just about covered everything. I don't have any additional questions to add on to what Dr. Corey asked.
Same.
Okay. Yeah. Level of experience. How long have you worked here?
Almost 5 years.
5 years?
I was PRN forever.
Okay.
And so just worked like once a week.
Uh-huh.
And then like September, October, I've been working more full time.
Okay.
So never have seen anything like that.
Yeah. And all
Thank
labor
the
and
Lord.
delivery?
Yeah, for the last 5 years.
Okay. Yeah. And then Morgan, how about you? What's your experience?
I've only been here for a little over a year, not much.
Okay. Yeah.
I'm also
PRN. Okay. Okay. From talking with, some of the other people that have come through, it didn't seem like, at least to the knowledge of those that were here, that there had been an event like this at this facility, at least for the amount of time that we had some people here for, I think, 15 years. So it is a rare thing, but that's one of the reasons that I'm here.
Yeah.
We're doing training, and I think, this is such a huge opportunity to hear the stories of survivors and kind of getting that other part of it. We drill on kind of the clinical things that we're doing, but to hear, how this impacts people, and like she said, second, or survivor guilt, and, second victim, things like that, like it's real. And I think we have to keep that in the back of our minds as, opportunities if and when a situation like this were to happen.
It's typically the signs of the IC, a lot.
Yeah, and we'll go over that here in just a little bit, kind of the classic signs, but yeah, I just wanted to give you guys an opportunity to speak with someone, and I don't want to take up too much of Heather's time, but
thank you for sharing this with us.
Okay. All right. Well, thank you, Heather.
Yes.
I'll let you sign off. Morgan, if you want to stay on, I'm going to go ahead and play the presentation.
okay.
And I am recording this. If for some reason it cuts out, because there is a limit, I know, to how long it lets me record. I do have it recorded from the previous session, so we'll make sure and get that link out to everybody. But I'll go ahead and start that. Maybe wait for it. I feel like this is the button I need for a while. Sorry, hold on. There we go. There is volume on here. Unfortunately, I don't have a lot of control. It's all the way turned up. So just put your ears on.
A special thank you to the AFE Foundation for their assistance with this presentation.
Oh, it just says I'm sharing sound. I had the volume at the bottom. It was 100, but okay, well, we can do it.
Today we'll be talking about how to recognize early warning signs and symptoms of amniotic fluid embolism. We're going to look at the classic AFE syndrome triad and differentiate between proactive and reactive treatments. Amniotic fluid embolism has become more common in recent years for unknown reasons. The graph here represents percentages of pregnancy-related deaths in the United States as reported from the CDC in 2011 to 2016. Amniotic fluid embolism comes in at 5.6%. Of patients with AFEs, 50% of them die within the first hour of the onset of symptoms. In survivors of the cardiorespiratory phase, 50% will develop a coagulopathy. Most survivors have neurological deficits. A recent study in 2017 indicates a maternal survival rate of 15% and a neonatal survival rate of 50 to 80%. Of those that survive, 85% of moms and 50% of babies will likely develop neurological impairment.
Does she have any?
Despite its vast history, there's a lot still unknown about AFE. In 1926, the first cases were recognized and reported in Brazil. In 1941, Steiner and Lushbaugh defined AFE based on post-mortem findings of fetal squames in maternal vasculature. In 1948, Eastman is quoted saying, "Let us be careful not to make this a wastebasket for all cases of unexplained death in labor." In the 1980s, Dr. Stephen Clark began his registry, increased diagnostic tools, and review of cases began to disprove previous theories. In the 90s, Dr. Clark proposed a new name, anaphylactoid syndrome of pregnancy. Despite its greater relevance, this name was not widely adopted, and the registry ends. In 2008, the AFE Foundation and AFE Registry were established. Our general understanding is that the typical presentation includes the classic triad of symptoms: hypoxia, hypotension, and coagulopathy, but there's a lot that still remains poorly understood. In fact, 30 to 35% of cases are incorrectly diagnosed. And this is because we don't have a clear picture of the clinical presentation. There's other differential diagnoses or even ethical dilemmas that play into that diagnosis. We know that AFE is very unpredictable, rare, has a very acute onset, but unfortunately there is a lack of a gold standard for diagnosis. The previous theory of cause is that amniotic fluid is forced into the maternal vasculature. Cellular debris obstructs the pulmonary arterial flow, leading to hypoxia. In 2018, this article was published that suggested a different theory of cause. They studied specimens from 30 women at term at the time of rupture for both vaginal deliveries and C-sections to determine the concentration of amniotic fluid squamous cells in maternal circulation. Ultimately, they found that even if the entire volume of amniotic fluid were transferred into maternal circulation, and each of those squamous cells did in fact obstruct a pulmonary alveolar capillary, these obstructions would still remain undetectable. They concluded that the pulmonary effects of AFE are associated with an inflammatory process rather than a physical obstruction. We also know that fetal antigenic materials often pass into maternal circulation. So why do some people have such a dramatic response and others not? This leads to the current theory of cause, where passage of amniotic fluid into maternal circulation leads to an abnormal maternal response and an immune reaction. This is an important distinction because this may explain why the same treatment leads to drastically different outcomes. 80% of the time, patients are going to present with the classic triad of symptoms: hypoxia, hypotension, and coagulopathy. 20% of the time, there may be an atypical presentation. It's important to have a strict criteria for definition of AFE. Administrative data has shown a higher incidence with lower mortality. However, upon clinical record review, we actually know there's a lower incidence with higher mortality rates. There are currently no recognized risk factors with sufficient scientific validity to warrant any alteration in the management of labor and delivery in order to avoid or reduce the risk of this condition. The timing and onset of AFE symptoms occurs primarily during labor. 20% of the time, it occurs during C-sections, and 10% of the time immediately postpartum. There are a few cases of AFE onset occurring during other procedures. These are the recognizable signs and symptoms of AFE. Respiratory distress is reported in 93% of cases. 87% of cases report cardiac arrest and 83% coagulopathy. These signs and symptoms and central hemodynamic changes are similar to those seen in cases of anaphylaxis, SIRS, and septic shock. In its most classic form, a woman in labor or shortly after delivery sustains acute dyspnea, desaturation, sudden cardiovascular collapse, followed by cardiac arrest and/or coagulopathy. Hypoxemia causes 50% of deaths that occur within the first hour. Permanent severe neurological impairment or maternal brain death can result from profound or prolonged hypoxemia. The hemodynamic instability is both complex and variable. Initially, we see pulmonary and systemic hypertension, which leads to profound left ventricular dysfunction. The treatment of AFE is really going to focus on that classic triad: hypoxia, hypotension, and coagulopathy. We will support her by giving supplemental oxygen, supporting her blood pressure with volume and vasopressors, and giving blood products and hemostatic agents for coagulopathy. There have been some case reports of LVAD and ECMO use in AFE. We do not currently offer these services at Overland Park Regional, but do have options for Impella and intra-aortic balloon pumps. I would like to take a moment to talk about the proposed AOK therapies for AFE. It's important to recognize that there are no studies that have been done or will ever be done verifying the effects of these treatments. It would be unethical research to study this alone. This is strictly an anecdotal therapy and should not result in the delay of your code management. The only validated management of AFE includes management of the classic triad of symptoms and following the management of a code as recommended by the American Heart Association. This includes effective CPR, defibrillation if indicated, and epinephrine administration. The AHA removed atropine from the cardiac arrest algorithm in 2018. It currently only remains on the adult bradycardia algorithm. This is an example of a flow chart from maternal arrest and suspected amniotic fluid embolism. The first step being high-quality chest compression. We're going to anticipate a resuscitative delivery, activate the massive transfusion protocol to treat postpartum hemorrhage and DIC, maintain her blood pressure and hemodynamics with volume and medications, and get a bedside transthoracic echocardiogram to help visualize the structure and functionality of the heart. CPR on the pregnant patient is going to be the same as with a non-pregnant patient with only two exceptions: left uterine displacement and the 4 or 5 minute rule. With multiple people present, left uterine displacement is preferred over a 30% left tilt. While a patient is in a supine position, this results in compression of the vena cava. When tilted 30 degrees to the left, you experience reduced compression force and still compression remains on the vena cava. The heart shifts laterally during that tilt. Positioning of the hands should
Restart your computer, it says.
No. Snooze.
remain the same as a non-pregnant patient. Previous recommendations suggested moving hands up on the sternum, but there is no data to support this recommendation. Evacuation of the uterus by 5 minutes improves maternal and neonatal outcomes. Perimortem C-section should occur at the same site as the cardiac arrest. Do not waste time trying to move the patient to the operating room. CPR efforts are less effective during transport. If a patient is found to be completely dilated and the infant is low enough in station, assisted vaginal delivery can be considered. Defibrillation has long been a concern during maternal resuscitation. It is unlikely to pass much energy to the fetus in utero and is unlikely to have arcing to the fetal monitors. In fact, during resuscitation, attention should be solely on maternal status. Attempting to evaluate your fetal heart rate during this time is not helpful and may actually delay maternal resuscitation efforts. No medications should be withheld due to concern of fetal exposure. epinephrine has been shown to change cerebral and myocardial perfusion. Vasopressin has strong vasoconstrictive properties. Historically, there's been concern for other ACLS medications and fetal exposure. For example, amiodarone has an extremely long half-life. However, in 4 minutes, it is unlikely that you would get to the point of these medications during your resuscitation. Risk-benefit should always be weighed. Most medications have a small enough molecular weight which allows them to cross the placenta. However, maternal well-being is the priority, and fetal well-being is directly related to your maternal condition. Initial lab evaluation is very important for the treatment of AFE as well as ruling out some differential diagnoses, so don't delay. Fibrinogen is very important to diagnose DIC. Remember that fibrinogen is normally elevated in the pregnant or newly delivered patient, so a normal value is actually low. PT, PTT, and INR will not be abnormal unless your fibrinogen has dropped significantly. D-dimer is not particularly helpful for the pregnant or newly delivered patient due to the normally elevated levels secondary to their hypercoagulable state. The red top clot test is a quick way to evaluate for coagulopathy. Draw a sample and set it aside for 5 minutes. If a hard clot is formed at the end of that time, your fibrinogen level is likely to be greater than 150. If you have a semi-solid clot formation, your fibrinogen level is likely to be in that 100 to 150 range. If your sample remains liquid and no clot has formed, your fibrinogen level is likely to be less than 50 and your patient is likely to be in DIC. The diagnosis of AFE has traditionally been made upon autopsy after death. There's currently no gold standard for diagnosis. Based on what we know about the syndrome, the diagnosis is primarily based upon the clinical observation, the classic sudden triad, hypoxia, hypotension, and coagulopathy. Several investigators have proposed a more specific lab or autopsy finding. The search for specific histologic or lab markers continues. This condition remains primarily a clinical diagnosis of exclusion. The IGFBP1 protein is an insulin-like growth factor binding protein. This is being researched in AFE survivors. It is being found to be in much greater concentration in women with AFE than those without, those experiencing postpartum hemorrhage, and those with uncomplicated labor and normal pregnancy. It's important to be aware of support groups and resources available to patients that have survived AFE, families that have lost loved ones to AFE, or clinicians that have cared for these families. The AFE Foundation is a unique coalition of affected families, respected clinicians, world-renowned researchers, and engaged advocates working together to accomplish 3 key initiatives: advancing research, promoting awareness and education, and offering support to families. The AFE Foundation represents over 1,500 families with outcome-specific support groups. They have licensed clinical social workers on staff and a 24/7 crisis line. They offer support to clinicians, helpful guides for all outcomes, and annual training for advocates. They've partnered with several professional organizations to promote education. They've participated in clinical meetings, grand rounds, continuing education courses, online webinars, simulations and drills, and even podcasts. The Foundation strives to advance research. The Amniotic Fluid Embolism Registry is composed of over 200 self-reported cases and is the largest database of AFE cases. It is the basis for clinical research, specimen repository, and is the foundation for published papers on diagnostic criteria, management, and reproductive outcomes. The Survivor Clinical Summary Guide can be found on their website and aids in greater patient and family understanding. It summarizes significant aspects of treatment and the clinical course of events. It also assists in continuity of care and minimizing the triggers associated with retelling of the event. The AFE Survivor Guide is also available online to aid women and families through their journey of healing. At this time, I would now like to welcome an AFE survivor who will share her story and answer questions.
We did that backwards.
Yeah.
But that was perfect timing. She did not. I think she did have some issues like kidney function afterwards. But I think that was kind of her biggest sequelae. We had a different gal on with the last group, and she also did not experience really anything. Most of them, the gal in the last group kind of talked about it too. Most of them have very little memory of the event itself. So when they tell their stories, now in Heather's case, she didn't, you know, she was semi-coherent, right, up through the point where they actually put her to sleep. So she has some decent memory of that time. But the last girl, you know, she collapsed in the labor room. Her heart, you know, and everything stopped there. So her memories and a lot of when she tells her story is from what she's read through case reports, and what she can, you know, a lot of the survivors, that's the case. They look at their charts and they see this is kind of the progression of events.
Does it like hit like all of a sudden, or is there some warning signs to it?
No, unfortunately it does. It's very sudden. And that's one of the kind of hallmark signs of AFE is that you have a patient that's fine, and then they have something that's different. As Heather was saying, you know, she got violently ill. The gal before Miranda, she said that her demeanor just changed, and the nurse picked up on that. Like she got very anxious and agitated, and she was like, "This just isn't her." And I think we do a really, really good job as, especially labor and delivery nurses, normalizing the abnormal, because this is, for the most part, a really happy place to be, and this just doesn't happen that often. I'm thinking of a few other survivors that I've had the opportunity to hear their stories, and one of them told me that she felt like her feet were on fire. That was kind of one of her first symptoms. But really it was probably like a neuropathy kind of thing. She was hypoxic and she started like losing feeling in her toes and things like that. So we definitely don't want to downplay any, changes in your patient status. And we have a really unique opportunity in this role to be able to get to know our patients very well. And we spend a lot of time with them. So we should be able to, hopefully see some of these triggers that start to pop up. But yeah, it's you're fine. There's maybe something just minutely different and then collapse. It's a very quick thing. Yeah. Morgan, do you have any questions or anything over that content? We have, it looks like about 6 minutes before the Zoom's going to cut me off.
I don't have any additional questions. I guess you said it was a very sudden onset. I guess we could check into is there a typical protocol that a hospital should have as far as step by step? And I guess looking into seeing where I could find that in my facility.
Yeah. So that's a really good question. Unfortunately, because every AFE case is different, there is not a lot we can do to kind of streamline the process. The biggest things are going to be CPR, number one, and everybody in this unit is at least BLS certified, so everybody can jump on that chest. We don't do it very often, but everybody should be able to start CPR. The second thing you want to remember is kind of your algorithm from the American Heart Association. The first med that we should be thinking about is epinephrine. And that's what we should go to. As you saw in the presentation, there are other ideas out there for protocols, but there's nothing that has a lot of substantial research support. And that's just because there never will be. I can't say if you have an AFE, I'm going to try this, you know, try out of medications and see what happens. And if you have an AFE, we're not. And we'll just see what happens. You just can't do that. So the atropine, ondansetron, and ketorolac are the three that are proposed as a possible option. Keep in mind that the American Heart Association took atropine off of the cardiac arrest algorithm. So it is only on the bradycardia algorithm, which means if your patient doesn't have a pulse, it's probably not going to do anything for her. But what the AFE Foundation has said is, you know, they're not going to say don't try something that could potentially save your patient's life, but start with what we know works, and that's effective CPR and epinephrine. The other things would be, you know, educating not just your unit, but we need to reach out and get to the ER to, if you have like an ICU or critical care unit, even your OR teams, because they're going to respond in this case. And what we often see is these other teams respond, but as soon as they see that pregnant belly, they're like, whoa, not my space. But really what everybody needs to realize is that the CPR is going to be exactly the same. The code management is exactly the same. So they're not going to withhold anything. There's just a few exceptions, and that's the timing, and we need to position mom to get the weight of the uterus off the vena cava. Those are really the only exceptions. So, yeah.
Okay.
Any other questions or anything?
I don't have any.
Okay, well, Morgan, thank you for joining. I know it's going to shut off, but we are also recording the simulations. So I will have that available to get to Melissa. It'll probably take about a week or so for me to get all the links uploaded. But I'll send those out, and then she'll be able to share that with those that were not able to be here in person. But thank you for taking your time out of your day to join virtually even. I hope it was informational.
It was. Thank you so much for having me.
Yeah, you're welcome. Okay, I'm going to go ahead and stop the meeting then.
Great.
Thank
Bye,
you.
guys. Thank you. Bye.